Hello and welcome to Aging Well with Dr. Bob. I'm Dr. Bob Flaherty. I'm a family physician and today I will be discussing aging and medications. Most of us take at least one prescription or over-the-counter medication. These medications have been designed to work well with young and middle-aged people. However, as we age, our bodies change in ways that can affect many aspects of how medications work. In this presentation, I will talk about the special problems that seniors can have with medications and how we can deal with those problems. The information in this presentation is supported by high-quality medical research and expert medical opinion, and references are given at the bottom of many screens. This presentation is for information only. Before you act on anything you learn here, be sure to discuss it with your doctor, physician assistant, or nurse practitioner. Shakespeare said, "I have seen a medicine that's able to breathe life into a stone, quicken a rock, and make you dance canary with sprightly fire and motion." Well, we don't have medicines that'll make you feel quite that good, but medications are valuable. Between 1990 and 2015, U.S. life expectancy increased by 3.3 years, and it's been calculated that 35% of that increase was due to pharmaceuticals. That's the equivalent of one additional year of life due to our medications. However, as we get older, we develop more illnesses and we take more meds. This graph is interesting and useful. This is from a study that looked at people that took prescribed medicines for a week in England. Notice that the group of age 16 to 24, fewer than 20% of people took prescription medications. And of those that took prescription medications, it was usually one or two medicines and very rarely 5 or more medicines. But as we age, we take more medicines, such that by age 85 or higher, nearly 100% of people are taking prescription medicines in any given week, and over 50% of those are taking 5 or more medicines. One of the considerations with medications and aging is that of polypharmacy. That's defined as using 5 or more medications. These can be prescription medications or over-the-counter medicines. And in fact, only 5% of over-the-counter drugs are recorded on patients' charts, which means that doctors may not necessarily know all of the medicines that you're taking. And indeed, the more medications you take, the higher the likelihood of an adverse drug reaction or an adverse drug-drug interaction. Now, polypharmacy is not necessarily bad. There is appropriate polypharmacy where all of the medicines are prescribed to achieve the specific therapeutic objective. And medication therapy has been optimized to prevent adverse drug reactions. So taking multiple medications can be good if it's done appropriately and correctly. However, there's inappropriate polypharmacy, where one or more medications are prescribed than are clinically indicated, which can result in adverse patient outcomes and not achieving the therapeutic objective. The medicines can make you sick and don't make you better. Polypharmacy is associated with an increased risk of falls and frailty, disability, and mortality in older adults. In fact, the one-year incidence of potentially inappropriate medication use in frail elderly is 42%. Another consideration of aging and medications is what's called geriatric pharmacokinetics, which is how do medications work in your body as you age. This image is useful. This shows what pharmacokinetics involves. The first step, of course, is to take the medicine. So you swallow the medicine, it goes down into your stomach, and it's generally absorbed either in the stomach or in the intestines. After absorption, the medication gets into the bloodstream and is distributed throughout your body. And in particular, distributed into the water in your body, which can be in the bloodstream, but also outside of the bloodstream. But some medicines are also distributed into the fat cells in your body. After the medication's been distributed into your body, it's then metabolized. It goes through the blood and into the liver and the kidneys, where the medication is broken down into inactive ingredients. And finally, the last step is where the medicine is excreted. That is to say, it leaves your body through the kidneys in the urine or through the intestines in the stool. And the point of this, and the result of this, is that you get a steady blood level of the medication to target tissues. And hopefully, it's a good, safe blood level. However, drugs are designed to maintain a steady, effective, and safe drug level in the body. That's desirable. But it's based on the absorption, distribution, metabolism, and excretion characteristics of otherwise healthy young and middle-aged people, not older people. So a key question is, how well do medications work in older people? And the answer is they work differently and not necessarily as intended, because the changes as we age can make drug levels unpredictable. And as a result, 12%, 1 in 8 of elderly patients in U.S. hospitals are admitted because of adverse drug reactions. That's about 750 admissions per day. Let's look at why this can happen. Let's first look at absorption. The changes in our body as we age can result in variable drug levels. Absorption through the stomach wall in particular, is pretty well preserved as we age. However, a big change is that we make less stomach acid as we age, a condition called achlorhydria. With that decreased stomach acid, we can have decreased absorption of some drugs, especially delayed release drugs. But also with decreased stomach acid secretion, we can get increased absorption of certain other drugs. Some absorption of medications take place in the intestines, although we're not completely clear on how much absorption takes place in younger people, let alone in older people. And another concern is the role of the microbiome with drug absorption. That's the bacteria that live in our intestinal tract and have a lot of effect on a lot of conditions in the body. But the action on the absorption of medications is really not known. The next step is drug distribution, and changes as we age in drug distribution can increase drug levels. For example, the total body water decreases 10 or 15% as we age. We're actually a little more dehydrated than we were when we were younger. And that means that water-soluble or hydrophilic drugs reach higher peak plasma concentrations. The same dose of drug dissolved in less water in the body would give a higher peak plasma concentration, which can increase the effect of the drug and also increase side effects. But another change in drug distribution takes place as we age that can increase drug levels. Our total body fat increases 20 to 40%. That means that fat-soluble or lipophilic drugs can accumulate in our fat cells and then get released slowly. As a result, we can get prolonged drug effects and side effects because of the increased drug levels that can result. Let's look at the next step in pharmacokinetics, metabolism. and aging changes can result in variable drug levels that can be unpredictable. For example, our liver changes as we age. We lose liver cell mass by about 25 to 30%. That means there's fewer liver cells to break down the drug, which means increased levels will continue as we take continued doses. Also, as we age, blood flow through the liver is decreased by 35 to 40%, and with less blood going through the liver, less drug is broken down, and that'll result in increased blood levels. Separately, some drugs are broken down by the liver into active metabolites that have biological effects that can be desirable or undesirable. The end result of these active metabolites that are floating around and not being broken down further is increased levels of drug effect. And also, about 10% of the drugs we take are prodrugs. That is to say, they're not the active drug. They need to be partially metabolized by the liver to become active drugs. Examples of these are aspirin and Plavix, and some of the ACE inhibitors we take for high blood pressure. If these prodrugs are not broken down by the liver because of decreased liver cell activity and decreased liver blood flow, that will result in decreased levels of the active drug. Some metabolism takes place in the kidney, and changes in the kidney can result in increased drug levels. One of the changes is decreased kidney cell mass. We lose kidney cells as we age, so that in the elderly, cell mass is decreased by 35 to 42%. Also, as we age, we develop decreased blood flow through the kidneys, about 10% a decade after age 30, so that by age 70, we have only about 66% of the blood flow through the kidney. And as a result of fewer kidney cells to break down the drug and decreased blood flow carrying the drug to the kidney to be metabolized, we can get increased drug levels. The final step in pharmacokinetics is excretion of the drug. And aging changes result in increased drug levels. Excretion is mainly through the kidneys, so the decreased cell mass and decreased blood flow that I mentioned will decrease the amount of drug that gets into the urine and gets released from the body. But the liver also can release some drugs into the bile to be excreted. And again, the decreased cell mass and decreased blood flow will decrease the amount of drug getting into the bile and getting into the intestine and getting out of the body. Well, this can be a little bit concerning, and as you can see, can make for fairly chaotic drug effects. So what can you do to optimize your medications? Well, the key thing is to talk to your healthcare provider. And there's several things you can talk with them about. One is de-prescribing, and that is thoughtfully decreasing the dosages and the number of medications. Your healthcare provider will use most likely something called the Beers List. This is published by the American Geriatric Society, and it is an explicit list of potentially inappropriate medications that are typically best avoided by older adults in most circumstances where the risk of the medication may be greater than the benefit. And this is quite an extensive list, but at the top of the list are drugs like Xanax, amiodarone, aspirin, Celebrex, Ativan, Procardia, Ambien. These, as you probably recognize, are pretty common drugs taken by older adults. But the important thing about the Beers List is it allows healthcare providers to help you determine when the benefit of a drug you're taking is greater than the risks of the medication. It's a good and useful list. A second thing you want to Another thing to ask about when you are starting a new medication is whether you can go low and go slow. That is to say, starting with a lower than standard dose of the medication and slowly increasing it over a few weeks. I found in my practice that I could start with a low dose and go slow in increasing the dose and frequently end up giving a smaller final dose of the medication, but still getting good results for the medication. This would mean, though, you also have a lower risk of adverse reactions from the medication because you're taking a lower but still effective dose. And if you develop a new symptom, ask if it could be due to your meds. Our first reaction when you get a new symptom is that you've developed a new illness. But oftentimes, your new symptom can be related to your medication. And this can even occur if you've been taking your medication for a long time, because as our body ages and changes, suddenly the drug level might change. For more information about your medications, ask your healthcare provider, but also remember that your pharmacist is an excellent resource for medication information. Thank you for watching this presentation. I hope you found it informative and helpful. If you did, please click like below and subscribe to keep up to date with new presentations. And be sure to talk with your healthcare provider before you make any changes based on what you learned here today. Best wishes and age well.